Alright, musculoskeletal trauma.
Say what? Musculus. Huh?
Alright, we're going to talk about musculoskeletal system review, injuries to bones and joints, basics of splinting, and non-traumatic fractures. 45-year-old Dominic Foster rushes out the door of her office building running late as usual, she thinks. As she steps off the curb into the parking lot, she slips on a patch of ice, pitches to the left, her left arm shoots out relatively reflexively to stop her fall. As she lands on her outstretched hand, Dominic simultaneously hears and feels a snap just above her wrist.
I feel like she was trying to excuse me late.
So,
There's some shit like that.
So you ever stay?
what are some of the safety precautions for the EMTs and the patient in this scenario?
Check her airway.
That's a safety precaution?
No,
Be
that's
careful
not-
of patches of ice.
Alright, what signs and symptoms should they look for in their assessment?
Swollen areas of the wrist.
Alright, injuries to the muscle, bone, and joints are common. They can vary in severity from minor to life-threatening, and proper emergency care can prevent additional damage. Functions of the musculoskeletal system: give the body its shape, protects the internal organs, provides for movement, storing of salts and other materials, and it also produces your red blood cells. You have muscles, 3 types. Muscles can be injured in many ways. Overextending a muscle can break fibers. And muscles are subject to trauma, can be bruised, crushed, cut, torn, or otherwise injured, even if the skin is not broken. Muscles injured in any way tend to become swollen, painful, tender, and weak. Just like muscles, tendons and ligaments can be bruised, crushed, torn, or cut. They are included in the category of musculoskeletal injuries. Cartilage acts as a shock absorber between bones surfaces. Cartilage can be injured, leading to joint pain. Tendons and ligaments are, in a sense, the glue that holds the body together. As the body's structural framework, the skeleton must be strong enough to provide support and protection as well as jointed to permit motion. You have 6 types of motion. Flexation is the bending motion, moves the extremity towards the body. Extension is a bending motion, moves the extremity away from the body. Adduction, this is the movement of a body part towards the midline. Abduction, movement away from the midline. Rotation, this movement turns the body along the axis of a bone or joint. Circumduction, this is the movement through an arc or a circle from a central point. Skeletal system has 6 basic components: the skull, spinal column, thorax, pelvis, lower extremities, and upper extremities. Skeletal system supports the body and allows it to stand erect. The upper extremity consists of the shoulder girdle, arm, forearm, and hands. Bones of the upper extremities are the clavicle, scapula, humerus, radius, ulna, carpals, metacarpals, and phalanges. Lower extremity is made up of pelvis, thigh, leg, and foot. Your bones are pelvis, femur, patella, tibia, fibula, calcaneus, tarsals, metatarsals, and phalanges. Osteoporosis is a degenerative bone disorder associated with an accelerated loss of minerals, primarily calcium, from the bone. Paresthesia, distal to a fracture site, is a tingling or abnormal sensation, can indicate nerve injury. Anesthesia, distal to the fracture site, which is a loss of feeling, can indicate nerve injury. Paresis or weakness can indicate nerve injury. Paralysis, a loss of muscle control, can indicate nerve injury. Inability to move an extremity can indicate muscle or tendon damage. Decreased pulse amplitude, increased capillary refill time, paresthesia, or pale cool claiming distal to the fracture can indicate vessel injury. Alright, you have different types of fractures. Comminuted. Impacted, green stick, oblique, spiral, and transverse. You can have open and closed fractures. Closed does not break the skin. Open breaks the skin. That's what these look like. This is an open fracture. It's where your bone ends are protruding through the skin. Oh, was it? Alright, deformity is a sign of a fracture. Alright, you have types of injuries. You have fractures. Complications of fractures include hemorrhage, tissue damage, including nerves and blood vessels, infection, and interruption of blood supply. You have strains. A strain occurs when overexertion or overstretching causes muscle fibers to tear. Pain is usually localized with no edema or discoloration. A sprain is an injury to a joint capsule, the damage to the connective tissue, usually the ligaments. This injury causes immediate pain and tenderness with delayed swelling and discoloration. Strain, an injury to the muscle or muscle tendon, possibly caused by overexertion or overstretching. The shoulders, knees, wrists, and ankle are the joints most vulnerable to sprains. The patient typically experiences immediate pain and tenderness in the joint upon injury. The patient complains of pain and tenderness at the site of dislocation and typically is unable to move the extremity. A dislocation is dangerous because it can damage blood vessels and nerves by compressing or tearing them. That looks really painful. The force applied to the body can cause injury to the surrounding soft tissue, even to body areas that are distant from the injury site. Two specific fractures are associated with high incidence of serious bleeding and the potential for the patient to develop shock. A fracture of the femur or pelvis is considered a critical injury and must be managed not only to immobilize the bone but also reduce the associated bleeding. The bones of both the femur and the pelvis contain large blood vessel supply. When fractured, these bones tend to bleed heavily. Also, the bones are near other large vessels that might be lacerated by the bone ends, leading to serious bleeding. Retraction splint is applied to accomplish two goals. The bone ends are realigned, which further helps prevent injury and reduces pain. And the size of the thigh is decreased, which allows less blood to accumulate. Yeah, it's highly vascular. It's a lot more vascular than you think it is. If a patient is unresponsive, there are multiple injuries, or the mechanism of injury is significant, conduct a rapid secondary assessment. You want to check for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Assess the skin color, tip, and condition. Assess the pulse amplitude, and check for capillary refill time distal to the injury. The severe pain associated with a fracture to an extremity can distract the patient from complaining of other more significant pain, such as abdominal or spinal pain. This is why fractures are called distracting injuries. They're distracted to you and the patient. With open injuries, an open wound is associated with a fracture. The bone might protrude through the skin. Pain might be on palpation with movement or without movement. Pallor. Skin distal to the injury site may be pale and capillary refill delayed if an artery is compressed or torn. If a vein is blocked by a fracture, the distal extremity can appear warm, red, and swollen. Paralysis, the patient is unable to move the extremity. This might be from nerve, muscle, tendon, or ligament damage. Paresthesia, the patient might complain of numbness or a tingling sensation. This can indicate nerve damage. You can have pressure, the patient might complain of a pressure sensation with the extremity. This can be associated with swelling from damaged tissue or blood loss within the muscle and surrounding structures. Pulses, the pulse distal to the extremity may be absent or show a decrease in amplitude. This can indicate damage to an artery. If the patient has a life-threatening condition caused by or directly related to extremity injuries, such as femur or pelvic fracture with hypotension, or an open fracture with severe bleeding, immobilize the injured extremity during the primary and secondary assessment. If the appropriate resources are available and it does not cause delay in transport, then transport the patient immediately. Make sure that the patient's distal pulses, motor function, and sensation have improved and have not deteriorated because of immobilization. Alright, EMTs Kyle and Ella have arrived to the scene. Glad to see that the first engine has spread some sand on the surface of the ice to minimize the chances of further injury. They quickly complete a primary assessment and determine that the patient does not have a serious mechanism of injury or likelihood of spinal injuries. Their next concern is getting her out of the cold. The patient is doing a good job of self-splitting the injury for the moment, so they place her on a stretcher and load her into the ambulance before completing a modified secondary assessment. Kyle carefully examines Dominique's left upper extremity. She has a deformity and swelling above her wrist. Her radial pulse is present and strong, and the distal motor and sensory functions are intact. She also has a laceration on her left palm. So what kind of splints would we use? I'm down with that.
Okay.
What principles of splinting should you follow as you immobilize the injury? Above and below. Alright, splints are used to prevent movement of dislocated joints or bone fragments or ends and reduce further injury and reduces pain and chances of complications. Alright, splint is any device used to immobilize a body part. A splint can be soft or rigid. It can be commercially manufactured or improvised from virtually any object that can provide stability. If the patient shows signs of shock, align the patient in the normal anatomical position. Treat the patient for shock and transport immediately without taking the time to apply a splint. If a fracture of the femur or pelvis is suspected, splinting should be considered as a bleeding control measure. Splint the femur or pelvis at the scene only if enough resources are present so that it is not a delay in transport. Alright, before and after you apply a splint, assess the pulse, motor function, and sensation. You should evaluate these signs every 15 minutes after applying the splint. Remove or cut away all clothing around the injured site with a pair of bandage shears, trauma shears, so you won't accidentally move the fractured bone ends and complicate the injury. Cover all wounds, including open fractures, with sterile dressings before applying a splint, and then gently bandage. Avoid applying excessive pressure to the wound. You had a pedicure. If there is a severe deformity or the distal extremity is cyanotic or lacks a pulse, align the injured limb with a gentle manual traction before splinting. As a general rule, make one attempt to align the extremity. If pain or resistance or crepitus increases, stop. Generally, you should not try to realign a wrist or an elbow. Never intentionally replace protruding bones or push them back below the skin. Pad each splint to prevent pressure and patient discomfort. You want to maintain manual retraction until the splint has been applied. If the patient shows signs of shock, align the patient in the normal anatomical position. Treat for shock and transport immediately without taking the time to apply a splint. You have all different kinds of splints. You have rigid, pressure, traction, formable, vacuum, sling and swath, spine board, KD. Here's all of them. This is your bipolar traction splint. We're not going to go over how to do that. We're not really going to go over how to apply a vacuum splint either. You put it on, suck all the air out, and it splints it. Alright. Most ankles, I'll use pillows.
For your pillows.
Truck. Pillows, blankets. That's what I keep them on there for. For all their obvious benefit to the patient with a bone or joint injury, splints can also cause complications if they are applied in the wrong manner. Alright, always keep that in mind. Signs and symptoms of long bone injury: exposed bone ends, joints locked in position, paresthesia, paralysis, pallor of the injured site, loss of distal pulses. Alright, here's your long bone splinting. Stabilize, check BMS. If the distal pulses are absent or is cyanotic, align with gentle manual traction. Measure the splint for the proper length. Alright, ensure the entire extremity is immobilized. The hand or foot must be immobilized in the position of comfort or function. Reassess pulse motor sensory. If the distal extremity is cyanotic, lacks pulses, align the joint with gentle traction. If pain or crepitus increases, please stop. Do not spend time trying to differentiate a joint injury from a bone injury because it might be difficult to distinguish between the two. Splint it and transport. Alright, let's go through splitting a joint. And they have all this good handy dandy stuff. Splint it in the position found. PMS. Traction splinting reduces the diameter of the thigh, decreases the space in which bleeding can occur, and realigns the fractured femur. This helps to tampen on the bleeding, relieves pain, and reduces the incidence of internal injuries that would occur if a patient were transported without immobilization of the injured extremity. Remember that if you don't have to be certain of femur, you don't have to be certain that the femur has been fractured if the thigh is painful, swollen, or deformed. You should treat the femur as if it is fractured. Alright, traction splints. We only use those on closed mid-shaft femur fractures. If you suspect a hip injury, a knee injury, and an ankle injury, do not use this. This is probably why we don't teach it anymore, because we don't use them a whole lot. And people were probably using them and they had knee injuries and hip injuries and it was making things worse. Alright, familiarize yourself with proper splinting techniques for the upper arm, elbow, forearm, wrist, hand, fingers, pelvis, hip, thigh, knees, lower leg, ankle included. Use a commercial available pelvic binder or splint or an improvised pelvic wrap to splint and stabilize the fracture and tamponade the bleeding. I believe Acadian has these. I think Bastrop has them, or Pafford has them. However, I use a blanket and 2-inch tape. This is kind of what it looks like. It's a pelvic binder. Anytime today, computer. Alright, compartment syndrome develops over time and is not often seen in the field. Alright? What happens is pressure develops within the injured area. The pressure exceeds the capillary pressure needed to perfuse the tissue. The tissue becomes hypoxic, which results in further damage and swelling. Signs and symptoms: severe pain, burning, decreased strength in the extremity, paralysis, pain, extremity feels hard to palpation, distant pulses and motor sensory function may be normal. Emergency care focuses on treating any life-threatening injury first, immobilize and splint the area affected extremity, then elevate it and apply ice or cold pack. It is important to transport the patient because they can lose the limb if compartment syndrome is not treated quickly and effectively. Alright, pathologic fractures. The signs and symptoms associated with non-traumatic fractures are similar to fractures caused by trauma. However, non-traumatic fractures do not present with obvious evidence of trauma to the area of the fracture, such as contusions, abrasions, lacerations, and hematomas. Alright, Kyle selects a padded, rigid splint that extends from the patient's fingertips and just below the elbow. He carefully applies and secures the splint, then applies a sling and immobilizes the elbow. He reassesses the distal pulse, motor, sensory function. At the hospital, Dominique is diagnosed with a fractured radius and ulna and is told she'll be wearing a cast for the next 6 weeks. Alright, anybody have any questions about musculoskeletal trauma? Yes, no, maybe?